Hello, I'm Dr. Alexander Lyon. I'm a consultant cardiologist at the Royal Brompton Hospital in London and at Imperial College, and I'm also clinical lead of our Cardio-Oncology service. I'm here with Professor Joerg Herrmann, who is a professor of medicine and the clinical lead for Cardio-Oncology at the Mayo Clinic in the USA, and we're here in Sao Paulo in Brazil for the 5th Global Cardio-Oncology Summit, learning the latest science and treatment pathways and management for cardio-oncology. So, Joerg, we both set up our cardio-oncology services at the same time in 2011. What were the drivers for you to feel the need to set up a service like this?
So I think it was the recognition of the trends, important trends in this arena. The oncology, hematology colleagues have succeeded so much in generating more and more survivors over the years. Furthermore, we not only have more survivors, but looking at the trends, we're also going to have more elderly survivors. So meaning more survivors with comorbidities, including cardiovascular diseases, and then more long-term survivors. So these kind of elements, more survivors, elderly survivors, and long-term survivors with all the potential toxicities that then matter. Before, it was more or less a hit-and-run approach. You will get to the chemotherapy or whatever you wanted to administer, and then you don't really worry about the effects. And so this kind of survivorship aspect has really changed the landscape, and this was, I mean, to us, the main driver.
I mean, we know now, whether it's in the USA or in Europe, we have 30-40 million people who have either survived cancer or living with their cancer controlled as a chronic disease by regular medication. And I think we've both seen this explosion of new cancer treatments which are making a difference to cancer but are causing cardiotoxicity in various ways. I mean, what sort of types of cardiotoxicity do you see?
Well, it's the full spectrum. I think what this and what we're seeing here being presented field entails is all of oncology, hematology, and all of cardiology. And we're trying to blend this, the full spectrum. So my question is, how did you do this? I mean, because it's such a challenge to blend all this and to put it in a clinical format.
I agree. So I think that this is a partnership. The big message is cardiology can't do this on their own. You have to do it together with oncologists, with hematologists, hopefully set up pathways so you can see their patients rapidly, so they're not delays in cancer treatment, that the cardiology service can give them promptly. We have a day case model, so the patients get all their scans, their blood tests, cardiac tests on the same day, see us with the answers, and go home with the plan. Can they continue treatment? Do they need to start cardioprotection? The risks and benefits, and you're speaking to the oncologists and the hematologists, the dialogue as to what the absolute risks are, what the benefits are, and then personalizing it to the patient. But it requires pathways, and then as we've both experienced, this is exploding. It's really enormous now, so we have to train our next generation of doctors, both cardiologists and oncologists.
I fully agree, and then I mean the training, but also, and you've done this very nicely already, not only having the clinic being established, but and there are so many now. I mean, no matter where we look on the globe. What about outcomes and assessing what impact we make? Because skeptics, and particularly in the beginning, it was not that easy when we started, they would argue, so what? You know what I mean?
I think it's really important. I mean, we're here to improve care. I think to begin with, as cardiologists, we were focused on improving cardiac outcomes, and I think we do that. But actually, what we're finding is keeping people on their cardiotoxic cancer therapies, which we know are effective for cancer, keeping them on treatment for longer, preventing interruptions, actually improves cancer outcomes. And we have now data from our service. We got almost 90% of people who are having cardiovascular toxic problems on their treatment back on treatment and through to the end of their treatment safely. And this will deliver improvements in oncology. And once we as a community understand that, then you can get the support of the oncologists and the hematologists, because we're improving their outcomes.
Exactly.
So, and that's what we're sort of hearing at at this meeting, at the GCOS 2019 meeting. We've now got the launch of a dedicated JACC Cardio-Oncology journal. So, you know, these are the types of scientific research papers that are going to be published so that we can guide the community for the future.
Yeah, I fully agree, and it's a get-together, right? It's a get-together. It's a partnership.
And it's the future. This is going to be the next 20, 30, 50 years of modern cardiology, because we're following modern oncology and it's exploding.
Fully agree.